see in the previous talks, we have heard about the individuals per population per year who suffer from this, and the pulmonary embolism is the most severe complication, and we do have to do something about that. We know that we can effectively manage conventional with conventional anticoagulation. We know with an increase of medical complexity, however, not all patients are candidates for this medication therapy. It's about approximately 15% of these patients who are not suited for this therapy. In this case, we need to look for alternatives, and maybe vena cava filters are an alternative for these patients. When you place vena cava filters, you also have to think about complications. While acute complications are rather rare, most of the complications occur delayed or in the early post-procedure phase. The delayed complications, most of them suffer from post-thrombotic syndrome or recurrent DVT, which is observed in plenty of these patients, 21% as noted in the literature. Recurrent DVT is not unexpected because you have still the thrombus within the patients, and the rate of recurrent DVT following anticoagulation is approximately 50% of that in those patients with vena cava filters without anticoagulation therapy. There are some indications we have to respect while thinking about placing vena cavas. Actual indications are contraindication for anticoagulation and failure to anticoagulation. But the failure to anticoagulation may be due to the fact that it needs to be determined if the patient has been on a therapeutic dose of anticoagulation, and more appropriate to redouble the efforts on therapeutic anticoagulation or consider increase in target and ENR is more appropriate than placing IVC platelets. My slides are wrong there. No, I want to go forward. I'm pressing my L here. Anyway, looking at the literature, we can see that we have an increase in use of vena cava filters, especially in the US, based on increase in trauma patients. So far, there are only a few studies looking at these vena cava filters and the outcome in the prevention of thromboembolism. So if you look at those two studies being published in a randomized trial, you will see that there is no benefit for the long-term prevention of the complications. The PREDICT study, which has been published by a French group, as a follow-up of 8 years, they demonstrate that the prevention of pulmonary embolism is superior with the placement of vena cava filters, whereas the overall mortality is not. But if you look into the study, you will see that those patients who are in benefit of the vena cava filter, they are those patients who could not be treated sufficiently by anticoagulation therapy. So, in summarizing this, the recommendation, which here it is. Sorry about that, I can't see it here on my screen. I'll move forward to the final one then. Just show me the final on the full screen, I can sum up that. We know from the vena cava filters that approximately 30% of the vena cava filters are removed. Only 70% remain within the patient, and that makes things very dangerous. Systematic use of vena cava filters to prevent PE is not recommended, and this is evidence level B. Venous filters may, however, be indicated in certain settings of patient subpopulations if therapeutic anticoagulation is absolutely contraindicated or PE has occurred despite adequate anticoagulation, and this is evidence level C. So summarizing this, I think only a small subpopulation of patients really do improve from vena cava filter placement. Thank you very much.